So a very, very warm welcome to every single one of you who is here with us live, and to all of those of you who are going to be watching this later, either on catch up or on YouTube. Fantastic that you're here, that you're interested in learning more. It's going to make a difference. I know that already. So this is the first Dysautonomia Matters kind of gathering. I'm not quite sure what I'm going to call it, but I'm calling it a gathering. And we are here to add our voice to the wider campaign to get the topic, the subject, the condition of dysautonomia more into mainstream knowledge in the medical professional world. I know from speaking to many doctors that primary dysautonomia is taught at medical school, but secondary and idiopathic is not. And actually, most of you who are doctors will be meeting patients with secondary and idiopathic dysautonomia in your surgeries every day. And if you don't know it, if you don't know how to recognize it, if you don't know what the tick list is, you may be sending people away very confused, very lost, and without hope. And all of those states do not promote healing. I set up the Rest, Repair, Recover program in 2020 after my own slow recovery from COVID, after getting the most unwell I've ever been in my life, going into hospital, being told there was nothing wrong with me that they could find, and that I would probably just get better. And I realized at that point that my body needed more help than you'll probably just get better. So I intuitively set up a community of people to heal together. And that has become now the largest live taught program of autonomic nervous system regulating classes. And so we have worked with around 5,000 people, and we have a lot of people very vested in their GPs learning more, their healthcare practitioners learning more about this subject, so they can go in and have the right conversation at the right time in their journey. Because the sooner you catch this kind of condition in the stage that someone presents in the GP surgery, the better. So without further ado, I am going to hand over to the very first doctor that said, I want to share my voice with your community. I can help. It is the very brilliant Dr. Boon Lim. So Boon, why don't you tell us a little bit about yourself and then help us? Off we go.
Thanks, Susie. Great introduction. So my name is Boon Lim. I'm a cardiologist based at Imperial, and I run the syncope service. I'm also an electrophysiologist, so I do ablations. And the one thing I will say is that, I'm sorry to start on this note, Susie, but the local services, after many meetings and with a flood of patient referrals, have decided that we're not going to accept referrals from far and wide. So please do not refer if you're outside of our catchment area. And I think the more pressing point, Susie, and something we should take up, is that the ICBs, or integrated care boards across the country, have a statutory responsibility to provide appropriate services for the local population. And I guess if within your very let's say in the service that you provide, if you cannot find secondary care or anyone else to look after your patients or to see your patients, it's worthwhile questioning your local ICB whether they have an understanding of POTS and the prevalence of autonomic dysfunction syndromes in the local community, and what they are doing about commissioning secondary care provision, which appear to be very easily shutting because of whim and because people just don't want to see patients with autonomic dysfunction anymore. And if the services are not available, how they plan to develop it in the future. And to Susie's point, how they can provide training and education for healthcare providers who are interested in developing the skill set in autonomic dysfunction. So I guess that is the kind of state of play of a busy tertiary center now, which is we're flooded, we're inundated, and we are slightly struggling to make our managers happy because of the long waits. Now, you didn't come here to hear me rant or complain, so I'll just start my presentation, which is really about autonomic dysfunction. And if I put this on presenter view, Susie, can you just give me a thumbs up? Thumbs up, Susie, if you can see it, perfect. So this is my personal treatment paradigm, and I like to draw simple diagrams for my patients, and I think Please forgive me, I'm not going to show a p-value here, but I suspect that this is the narrative that most of us could use with our patients, and some of us could use with ourselves. So the paradigm is sympathetic versus parasympathetic. I don't need to belabor this point. Look at the slide, read it. It's what you all understand. But what I would like to say is that patients often think of a stress or a trigger for their conditions, and they can often, in fact, you all, or some of you in the room, can often think of a singular point at which you develop an infection or had a very triggering few days or a single day thereafter you had severe symptoms consistent with autonomic dysfunction. And in the era of post-COVID, then it's typically a viral infection or an immune reaction to a vaccine, and that led to autonomic stress and autonomic dysfunction. And then we all know about postural orthostatic tachycardia syndrome, orthostatic intolerance, sleep disturbance, chronic pain, gut peristalsis, which are all manifest outcomes from shifting from an autonomic balanced state, which is my yin-yang symbol, 50-50 yin-yang, to a dominant sympathetic state in black here, there about 75-25. And what I would like to say here is that medics in general are very good ologists. In fact, if you take the parable of the blind man and the elephant, where every of those blind person asked to describe an elephant will describe the elephant very differently. Well, we are just like that. So the person who approaches the elephant, who's blind and touches the side of the elephant, will claim that the elephant looks like a wall. And that person is right, because the elephant to that person is a wall. So the ologist, like me, a cardiologist, who sees a patient with palpitations, will say that autonomic dysfunction is about palpitations. And so we go on to great lengths to treat palpitations. Number one treatment, beta blockers. What do? They drop your blood pressure, they make you feel tired, lethargic, and they often, in most patients, spiral your symptoms. The other ologist approaches the elephant from the tail and tugs on the tail and says the elephant is like a rope. And so autonomic dysfunction is all about chronic constipation and diarrhea and intermittent IBS-like symptoms. And that gastroenterologist is right. Autonomic dysfunction does present with that, and you can treat that in the way that you know how. And so on and so forth. There are 6 blind men. There's a rheumatologist, a dermatologist, an immunologist, infection disease specialist. And there are all of you in this room who have got your own subspecialty and sub-training. But what we all fail to really see, and I'm included, and I'm guilty, is that I don't see the whole elephant. I see the version of the elephant or the side of the elephant that is showing itself to me and that I know how to treat. So as a POT specialist, I'm really focused on orthostatic intolerance. I do the tilt table testing. I prove that somebody has adrenergic stress during head-up tilt, blood pressure drops, and we can treat that with things like midodrine, fluorocortisone, compression leggings, and all the conservative strategies to enhance orthostatic tolerance, which may help, but it's not the only picture. Likewise, a gastroenterologist might do the same with giving you treatment and therapy that improves your bowel transit, decreases bowel pain, and can help in that way. But if we move along the paradigm, what I often see is that patients who have the autonomic triggered stress, if you ask the questions deep enough about the coexisting stress, and this is typically at the time or preceding the COVID infection, perhaps sometimes for many years, and ask the questions about school, work, career, finance, performance, and all these kind of things that set up your autonomic state to react in a way to a trigger, which could be COVID or a vaccine, and ask what impact not being able to cook, clean, shop, have a shower and raise your hand to shampoo your hair, chronically, day by day, what impact does that have on you and on your mental state? The inability to perform these simple self-caring tasks that we all take for granted, we don't even bother asking most of our patients if we're not occupational therapists. And certainly, I'm guilty of this as well. But the impact of the lack of ability to do this simple task has a huge kind of underestimated impact on mental stress. And stress, as we think, are kind of ways in which we can shift that autonomic balance chronically from a balanced state to a fight or flight dominant state. We bring in emotional stress, and after a chronic period of illness or even an acute illness, we look at exploring relationships, our home situation, and how we regulate ourselves, the emotional self dysregulation when it comes to being triggered every day by your symptoms and by not being able to do the things that we take for granted. And this is something that I start to see now after a 2, 3, 4-year period of chronicity of stress. And this is what I call spiritual stress, where after this time, for those of you who are medics or healthcare professionals who haven't been able to fulfill the full-time demands of your job, which is already quite demanding, those of you who yourself have long COVID and dysautonomia can often be faced with this very challenging, deep-seated concerns that what I say to my patients would be, when was the last time you spoke to your best friend at school who you could share everything with and you could cry on their shoulders? Because this is not about sharing with your spouse or your doctor or your colleagues, because they've seen this slow, insidious change in your personality, in the ability for you to be resilient. This is somebody who was your best friend, who you're in contact with once every 6 months, to come back to them and say, look, it sucks. Life sucks. I need to let it out. And I need you to know, or I need to share with you how tough it is. And that's spiritual stress, where you confront the meaning and the purpose, and you overcome that challenge to redefine yourself. And I think here Susie has a wonderful story to share about her own journey, which we might not have time for. But sometimes from the greatest of tragedies come a transformation. And in Susie's case, a yoga studio of 6 face-to-face people once a week to 5,000 people with the largest long COVID platform. What a blessing, Susie Bull, for you to have had the horrific long COVID to transform your life. I know when some of you saying this or watching this will say, how dare he say that? It's so insulting. But sometimes your situation forces a perspective shift. You either roll with it or you fight it. And in the fighting is a stress, a spiritual stress. And so my paradigm is that it's not all about the vaccine. It's not all about the COVID or the glandular fever or EBV. It's about all of these things, and they come in to shift your autonomic nervous system state at various times in your long COVID chronic journey or your chronic autonomic journey. I would say at the start, it's more physical stress on a background of chronic mental and emotional stress. At the end is mainly spiritual stress. And the question is, when we think of this stress curve paradigm, which some of you might have seen, we all, of course, want to work in this very, very steep slope, the zone where 1 unit of performance gives you 1 unit, or 1 unit of workload gives you 1 unit of outcome, i.e. performance. But my experience is when you look at patients who are teetering on the edge of the cliff, where 1 more unit of stress in the form of a vaccine or an infection makes you fall off the cliff of performance in all domains, including putting up your hand to wash your hair with shampoo. This is the paradigm that I sometimes share with my patients. And if I look at the summary of risk factors for long COVID, the main one that I have seen again and again in my patients is the inability to rest during the initial illness for various reasons. School run, have to work, have to hold on to that job, and not able to let go to any of the 5 balls that we're juggling. And in doing so, you drop all the balls. Now, shifting now is the important thing to do. So recognizing how we shift in the one direction, we now need to think about how to shift from the bottom symbol to the top symbol, how to get back to autonomic balance. And in physical strategies, what generally medics are good at, we correct, in my personal opinion, the orthostatic intolerance symptoms. Because if you're getting tachycardia every time you stand up, at least get rid of that, because that is a prevailing, pervasive, day-to-day higher level of adrenaline that you're going to be sitting with just by sitting down and watching the Zoom consult, or standing up, or just doing things. So if you can try and adopt strategies. And if those simple strategies don't work, like fluid salt compression, consider seeing a doctor. And you have to be lucky enough to live in an area who has a doctor who is brave enough to prescribe this thing that they've never prescribed before, called midodrine, if your blood pressure is low. And here lies the challenge, which I said at the beginning of the talk. And then we have those patients who can flare up with a rash when they stand in the shower, or they have susceptibility to hives or allergic reactions. And those patients can really calm down their autonomic flaring symptoms by calming the histamine release with a combination of histamine and 1 and 2 antagonists. We have post-exertional malaise, another form that triggers stress on the physical domain, and I'm not going to talk about that. We set a routine for sleep recovery. We do breath work, which is a pet thing of mine. I love breath work and I love to recommend it. And I would love if all patients, and maybe some of you watching this, could just learn what it feels to plunk your autonomic nervous system from sympathetic dominance to vagal dominance by 2 minutes of breath work. It can be done, and I'm often doing this in between patients, especially if I'm running late. Just a 1 minute breath work exercise can visibly shift my state. And then a routine for recovery and rest. On the mental and emotional side, I don't have very strong psychological narrative, so I'm not trained. But I would say that in my discussion with patients, if I have time, I will go through all these things. And here, this is actually taken from a talk I did at Heart Rhythm UK. And I did genuinely put Susie Bolt's name there. This is not here because of the talk we're doing, because this is a really safe space where Susie holds a really comfortable environment for people to share. And this tribe approach where people can come into a room and understand they are not alone, and they are supported in many, many different ways, in many different classes, in different domains of recovery, like meditation, breath work, tapping, yoga nidra. These are all helpful. And then spiritually, this is tough. And this will be tough for you to sit with and tough for you to communicate to your patients. But I would say sitting into the present moment, not fearing the future, not being angry about the past, and programs like the Rest Recovery Repair program may be very helpful here. I think the top tips that I would like to say in the last 2 minutes would be, we have to listen to our patients a lot more than we're given time for. And part of your stress alleviation is to understand that you will be delayed. And if you accept that you will be delayed, somehow you're not as stressed yourself. You also have to protect yourself. And I really feel it's worthwhile spending a little more time, because if you spend a short time and you send them off for diagnostics without talking about this kind of multifaceted approach and the narrative for multifaceted healing, but also the manifest symptoms, what I find my patients doing is saying, but doctor, I've got gut issues, send me to a gastroenterologist. And you go, okay, 6 months down this merry-go-round, they come back, normal endoscopy, normal colonoscopy, nothing to do. Oh, doctor, I think I have a problem with mast cells. I need to see an immunologist. And you send them, no one accepts your immunology referral. And then they come back 6 months later. Why not tell them the story of the elephant straight away? And on that, I think I'm 15 minutes up, right, Susie?
You are, you're done.
I'm done. I'm going to stop sharing.
Stop sharing, yeah.
Okay.
Brilliant. Okay, fantastic. Boon, really clear from your perspective, the kind of approach that you take. And I know that, you know, pretty much everyone that comes through your clinic is dealing with, you know, POTS, which is one of the conditions that falls under the umbrella of dysautonomia. I'm wondering, do we have, and I know the team have been looking in the chat box, are there any questions or comments that you want to share, folks? Do wave a hand and we can begin that. Is there anything that you want to read out? Claire?
Yeah, shall I read out a couple that I think are quite relevant, if Boon could answer? Can you discuss about the overlap of OI, orthostatic intolerance, and POTS? And people are sometimes fixated by a drop in blood pressure, but heart rate may be going up by 30 to 40. I think, could you just give an overview of the orthostatic intolerance syndromes, if you like, because that's the kind of umbrella thing, isn't it? and it's what comes under that.
Yeah, so at a high level, we have autonomic dysfunction. Below that is, or one of the things below that, only one, is orthostatic intolerance. And that simply means when you stand up, you cannot tolerate that. So you're intolerant to standing. Below that are other syndromes, including postural orthostatic tachycardia syndrome, a very specific definition which I dislike myself. But it is a form of orthostatic intolerance, which is in itself a form of autonomic dysfunction. The other orthostatic intolerance symptoms include vasovagal syncope, for example, of which there are situational syncope, reflex neurocardiogenic syncope, cardioinhibitory syncope. So there are many forms of orthostatic intolerance symptoms. And then there's early orthostatic intolerance and delayed orthostatic intolerance. So here we are focused on what your reaction is in terms of your adrenaline state when you stand up. And what we use, because we don't measure adrenaline in most units, we use the surrogate for adrenaline, which is heart rate. And that's why apps like Visible, for example, some of you will know, it's an armband polar tracker, will just track your heart rate and base your pacing points on that heart rate response. Because if your heart rate rises, you're activating adrenaline. And the reason you're activating adrenaline is because your blood pressure is dropping and your body needs to reflexively compensate for the blood pressure pooling in your lower limbs and in your splanchnic bed. So the adrenaline and noradrenaline comes in to vasoconstrict, to give you tachycardia and cardiac inotropy, where the heart beats stronger, to elevate your blood pressure. I hope that answers the question, Claire.
Right. Do you want to ask one more, Claire?
Yes, I think this would be useful. Somebody asks, is there any chance of a guideline document on midodrine and ivabradine to give GPs and other doctors a baseline for prescribing?
Great question. We have just been commissioned with potsuk.org, which I hope is one of the organizations we'll talk about later on, to write a proposed article on management of POTS. And in this guideline, hopefully, which we'll publish in the Heart Journal, which is the journal of the British Cardiac Society, we will use that to push NHS England to allow commissioning of things like midodrine and ivabradine. And this is expert consensus that goes above and beyond the stuff that normally takes years to do with the need for many randomized controlled trials. So I think the answer to the question, Claire, or whoever asked it, is it's coming. We're in the process of writing those, writing that in a document which will serve as the basis for hopefully a national guideline.
Fantastic, Boon. Thank you. I am going to move us on, but there's just one thing. Now, Claire, you and I were at the conference recently at the Royal Society of Medicine, and I think we learned about, and I think you may have known about it, the Form 31, which was that was very easy to access form that you can get from the internet that will help a diagnostic process just in the kind of that first prime GP level.
I'll mention it under resources.
Brilliant. Okay, great. As long as we've got some pointers for people, that would be amazing. Okay, we are moving now. Deepak, it's your turn. Deepak, introduce yourself. Come on in. Welcome.
Thank you so much, Susie, for inviting me. And good evening to all of you. Good morning and good afternoon to different parts of the world that have logged in here. Just going to share my slide because I know the 15-minute point starts. Again, Susie, if you let me know when it has gone to slideshow mode, which I'm just trying to get to here. Right. Yeah, brilliant. So Susie asked me to talk about dysautonomia from the experience of sort of being in the coalface and in a long COVID clinic. And that's where my experience stemmed from, is that I helped establish the Berkshire Long COVID Clinic, and I was involved along with one of the professors here in the UK called Trisha Grinog, where we submitted the initial first paper to the House of Lords that was taken up as some of the evidence base required for the UK government to release the first tranche of £10 million so that long COVID clinics could be set up. So UK still was the first country at that time which actually allowed for almost 90 such clinics to be put into place by the end of 2020. and I got the opportunity to lead such a clinic, develop and build and kit out a complete clinic like that with the help of some really wonderful colleagues in my area of Berkshire. So I work in Berkshire, which is about 20-30 minutes west of Heathrow, for those of you who want to orient your geography on there. And Reading in the Royal Berkshire Hospital was the clinic base. But we made right from the outset in terms of commissioning to work with our community colleagues to have a more full-fledged clinic. I'd like to think outside of the big centers like UCL or Leeds or many other wonderful tertiary kind of centers. We were one of the DGH that had a really well-established MDT team from the outside, with a GP colleague, with myself as a consultant, with physiotherapists, with psychologists, with an occupational therapist, and access to BCSCs and people in the community. And indeed, we were fortunate enough to be featured in the British Medical Journal on what happens in a long COVID clinic. I did have a case study prepared here, but then I realized that we have only 15 minutes there, but it's about 6 minutes. And the reason I had this on, and maybe I'll have a minute or two of this person presenting, because it was one of the first times, and for me, dysautonomia before that, as a pain physician, I used to see the occasional functional neurological disorder patient who would be referred to the secondary care pain service, or there would be a few fibromyalgia patients who would have a separate diagnosis of POTS, and that was only reason that I used to encounter dysautonomia, or something that I now recognize and understand as dysautonomia. Susie, can you just tell me if you hear the audio?
I don't.
Can you hear the audio at all?
We can only hear a tiny bit of her background.
Can you increase the volume?
It is at maximum over here. That's fine. Gives me an added reason not to confuse the issue there. I think I'll send it through. Maybe the Zoom setting here, I have to share sound possibly, but don't worry. But this was a young lady from the University of Reading who presented to the long COVID clinic here. We did have the benefit of having a tie-up and collaboration with a cardiologist, with one session of support from our local cardiologist, and she referred this patient to us because she has presented to the emergency department 4 times within a week with palpitations of sudden onset after a COVID infection, followed by extreme breathlessness. And so she was seen by the respiratory and cardiac teams on 3 occasions in emergency department, had echocardiograms done, had treadmill done. She went for a Holter. She was investigated by the cardiologist with all kinds of blood tests looking for possible myocardial problems of myocarditis and pericarditis, which they recognized were possible outcomes or sequelae of COVID. But this was 3 months down the line, and that was the time when she got referred to us, saying that, well, nothing was found on cardiology and respiratory investigations, but here she was struggling there. Rachel worked with us, so that was her name, and she was with my team then for a period of 7 to 8 months. And cases like her started to come through almost every week or other week. And that is where I was able to learn this whole pattern recognition of seeing a number of patients with what now I recognize as classic dysautonomia, or a variety of presentations there. And I think for me, it's a shame that I'm hearing so much about how so many long COVID clinics in the UK and probably globally are just shuttering down, partly because we're not testing enough. The number of cases are not that many. The strains may be less virulent, but the cases are definitely high, but there's less conversation. And it's such a challenge. I recently heard that out of the 90, we've only got about 35 or 40 that are now left running in the UK. There's been a change in how the business direction works. So I worked with my service for 4 years, and I was fortunate that in my area, because my colleagues and me were already looking after fibromyalgia patients and a few ME patients there, at the end of last year, our ICB and our local area insisted that our long COVID service will be protected and supported if we continue to see ME, CFS, and fibromyalgia patients as well. In some ways, that's kind of where I saw the pattern there. So my service in there, when I handed over to my managerial colleagues in the community, meant that we had medical oversight, we had physio, psychology, or not osteopath, occupational therapists with the whole set of counseling and support required. But this is what we know was the challenge of long COVID for a long time, and the numbers haven't really changed. We know it's a multi-system problem, and dysautonomia similarly presents in the same case. For me, in the clinic over the last 4 years, where we saw more than close to approximating 5,000 patients there were some common themes that were coming through, and especially where we saw the overlap of dysautonomia, it was this component of pre-existing anxiety, mental health issues, atopy, meaning an immune system vulnerability of some kind, history of migraine, hypermobility, and latterly neurodivergence. These were all starting to come through with what Boon had already mentioned, the physical and psychosocial stress that has a huge impact on their occupational health. Because a lot of the patients that came through were also working age adults who did not have a severe COVID infection that required hospitalization, but relatively what we thought or labeled as mild. And by the time 23 came along, there were enough papers coming through that were talking about POTS, but more than just POTS. And I think this is where we now realize that there might be circulatory features that present in a variety of fashion, but dysautonomia in itself is a huge umbrella diagnosis. Indeed, there were some papers coming through that actually suggested that within dysautonomia, we are looking at a variation of which part of the autonomic nervous system, parasympathetic or sympathetic, was more impacted. And some studies were suggesting that the parasympathetic part, the vagus mediated part, is probably much more affected than the sympathetic system. All of this has relevance in how people would respond to treatments. And as many of you are aware, and I think the recent work by the Royal Society of Medicine looked at this really expanding evidence base that's coming through to say, well, what might be responsible for the autonomic nervous system going off balance? And these are all the various studies that have been suggested, done in animals, done in humans, done in microscopic lab level, to suggest that we are possibly seeing some overlap of inflammation, immune activation, neuronal injury, probably some mitochondrial problem. All of this needs to be further elucidated, but these are all possible mechanistic theories now. I think one of you asked there, and I thought Boon would also cover this, but as Boon suggested, secondary dysautonomia, that concept that we are now recognizing in a lot of these post-viral condition, post-stress conditions there, is got three types of intolerance, orthostatic intolerance syndromes. There's orthostatic hypotension, there is the POTS, which everybody is aware, but there is then the syncope, which a lot of us recognize and see in many other parts of any. And these are the definitions for orthostatic hypotension and POTS, as you can see here. And I'll leave these slides there. I know Susie would have them for you there, but these are the broadly how we were defined and told that this is what you need to do to diagnose one or the other. But in clinical places, in the long COVID clinic and in most clinics where I was seeing a broad spectrum of patients coming with a wide variety of symptoms, in a long COVID service predominantly, and certainly in my practice there, the red is what we were able to do clinically. I'm giving you the other ways to evaluate the sympathetic and the cardiovascular system there, how you can evaluate them. But the sympathetic system is what we were evaluating with the NASA lean test. That's what you see in red on the second part here. And in terms of heart rate variability, where patients were coming with HRV trackers or Elite or these wearables that could measure it, I was taking some data from them. I used the Compass 31 score for a few patients there, but it was difficult to do it in routine practice. And actually, the number of patients that were coming in the clinic with so many symptoms were so much that actually at some point it was easy to make a clinical diagnosis. And sometimes, as Boon said, I was able to avert and my team were able to reduce the number of referrals to gastro or immunology. We didn't have immunology in Reading, or to other specialties, by actually just sitting down and validating and explaining this autonomic dysfunction and helping patients make sense of this wide cascade of symptoms and actually see that they are linked to an autonomic imbalance. I think the heart rate variability is something that nerve conduction study is something that we did as another set of testing, which we were able to do through our neurology colleagues. But the heart lock study, which was a feasibility of looking at heart rate variability biofeedback technique, just came out last year. And I can talk about that in the Q&A if required. But that showed that it is possible to use wearables to help patients use heart rate resonant breathing technique, something which probably Susie teaches as part of your reduction. There's a lot of information about POTS there, but tilt table testing is not something that routinely most cardiologists were able to do. I think Boon is one of those who does believe, I think there is a little bit of variation. My cardiologist in my area felt that there was no point doing tilt table testing, so that was very rarely done. But a lot of the blood tests were what we were able to do, and to then look and rule out various other autoimmune conditions, EDS, MCAS, all of these were things that I became familiar with, my team were comfortable with managing and supporting patients with. And these were broadly the non-pharmacological options that we were able to support our patients with using our MDT team, from education, from gentle movement-based strategies based on their symptoms, looking at triggers, looking at conditioning, talking about and advising on compression garments, looking at mental health support using a variety of these resources. My own physiotherapy and psychology colleagues used to ACT and a psychology-informed practice, but where appropriate, some online resources there. And pharmacologically, I have and used to prescribe ivabradine, used to prescribe midodrine, were capable, and depending on which patients come through, some of these drugs, especially the heart rate reduction, the volume expanders, and the vasoconstrictors, we were able to use in combination and discussion with the cardiologist on a few patients. But broadly, I'd say the results were often mixed, and patients often benefited more from a broader holistic approach and support rather than the drugs themselves. And I think that's important to emphasize, that it was a combination that made the difference in some people. Of course, there were some in whom ivabradine and the heart rate reduction really made a big difference. I'll end with this fact here that actually what we now realize is there's a lot of challenges, and it's unfortunate, as I said, that some of the clinics are all being shaped or closed, but where it's existing and you have a good MDT team, you can make a difference in the support of these patients. You can create that set of resources and support possible. Of course, I'm always going to say more research is required there. But my take-home messages are going to be that dysautonomia itself is a massive umbrella disorder and is often very under-recognized. My suggestions would be starting from a good assessment, considering management or diagnosis tools like the Compass 31, looking at heart rate variability options there. But right now, if you wanted to learn more, some of the signposting resources that I think are the Bateman Horne Center's 2025, they've got a fantastic clinical edition PDF that's free to download on the internet. Dysautonomia and POTS UK are standard sites that I suggest other patients to. My cardiology colleague that I could refer both privately and sometimes to the NHS, so the waiting times were ridiculous there, had been Nick Gall and Boon Lim here. And then in terms of online resources, a few of the apps that I suggest were the FreeMe, the Curable, and of course Susie's website and support has been invaluable in terms of how I used to refer patients to. And this is, I think, the best we can do for our patients now is giving them peer support and options. So thank you, Susie, for the work that you do and for the awareness raising. But this has been a quick sort of whistle-stop tour of what happens in my experience in the long COVID clinic.
Amazing, Deepak. Thank you so much. We whistled through that. My goodness. I'm hoping that you're going to say we can have the slides so we can send them out to everyone, because I'm sure all of us want to go back and look again. Now, what I can see in the chat box is some fantastic questions, some huge questions. And actually, there's quite a few people talking about the links with hypermobility, EDS, JHS, that kind of thing. And I know Claire and I reviewed the conference that we both attended on the links between those conditions and the chronic kind of long COVID and ADHD neurodiversity piece. we reviewed that together in a YouTube talk. So do have a look on my YouTube channel, because that was a fantastic day-long conference that we summarized, didn't we, into a fairly succinct 45 minutes, but really worth knowing. And I think someone even mentioned their endometriosis, which I think was being discussed at that conference as an autoimmune condition. So it links in with the dysautonomia piece. So are there any questions that you guys can see in the chat box that you'd like to pick up? Boon, I think there was one there with your name on it from someone, but I'm not sure if you've spotted that.
I think I've answered that question.
Oh, did you? Fantastic. Okay, Claire, is there anything that you've spotted?
A while back, somebody asked about, do we need to be doing tilt tests in everybody? I don't know if you want to answer about that, Boon.
Yeah, I don't think so. I think there are going to be on the POTS UK website, but certainly on my own charitable website, stopfainting.com, a link to an active stand test. So there are two ways to do this yourself and for your patients. It's a passive or active stand. An active stand is when you stand up and take the blood pressure sequentially from a lying position for about 7 minutes, and you document symptoms. And you can often make a diagnosis of POTS if they manifest symptoms and the heart rate rises by more than 30 beats a minute. A passive stand is similar. You stand the patients about 6 inches from the wall, legs shoulder width apart, and you're leaning the back onto the wall, so they're more supported. And importantly, for both these tests, you don't want the patients to be fidgeting or moving their toes up to the ceiling to cheat. So you don't want to engage the muscular contractions in the lower limb that can often artificially elevate the blood return. So you can do this and you don't need a tilt. The tilt is funky and is good for research, but you don't need it for a clinical diagnosis.
And actually,
that's what the NASA test is all about there. The
yes.
active test is the NASA lean test, and there's enough resources on the internet for you to just take off. And my colleagues and my physio in the clinic, we just printed out, we've got it on the wall there, and it was only resourcing, because to do it still takes time. And sometimes when you want to have a 45-minute consult for the patient, we had to get the patient back on a second time when they come to see the physio or the occupational therapist to do the lean test on that time if we ran out of time in the initial consult. But it's a fairly easy, straightforward test to do, and really, I think there are very few centers, Boon, isn't it, where tilt is actually offered in the UK. There's I think, apart from yourself, I'm not aware of anything in the Southeast.
I think that's true.
Yeah. I think the upside to that not being as available is the tilt test is quite an invasive experience for people. And I know quite a lot of people have had tilt in our community and come back and gone, my goodness, it took me a week to recover from that. Whereas the sit stand test is much more simple, and the patient has much more kind of ability to vocalize. I need to not do this now. So maybe there's a good thing in that. I don't know. Just throw my tuppence in there. Fantastic. Do we have any other questions? If not, we can jump into Carolyn straight away. Should we do that? Are you ready, Carolyn? This is Dr. Carolyn Forsyth from NHS Highlands, and she has her own lived experience of this, which is of huge value because it brought her a paradigm shift in the way that she treated people. So Carolyn, hello. Oh, hang on a minute. Let your internet just catch up with you a minute.
Lovely to see you all. Although I've told Susie, it's just
Carolyn, if you can hear me, Carolyn.
So my name is Carolyn Forsyth. I'm a GP in the Highlands of. Oh,
I think your internet's a bit squiffy.
Can you hear me now?
I think we can.
Hear me?
Your mouth and your sound are not synced yet.
2 seconds.
You can try turning your video off if you want to talk, and that will reduce your demand on your connection. See how you feel. I don't want you to, but that might be a solution for now.
One trick.
She's got a trick. We like a trick. Don't worry, it's fine. It looks like she's switching provider. there has been, just to fill in the blank here, a huge outing of internet resource today globally. We lost access to a whole bunch of our program for around 2 hours. So yeah, I think there's something going on in the ether. What we could do maybe while Carolyn is sorting this out is maybe jump to you, Claire, which kind of throws our scheduling slightly, but we'll fill in the gap so that we're making best use of our time. You okay to do that?
Yes, that's
Fantastic.
fine. I'll talk a little bit, then I've got a few slide resources which I can show, and then we'll share them afterwards.
Okay, super.
Okay, so I'm a consultant occupational physician. Before that, I did do general practice, so I have some inkling of what that's like. But I'm also an educator, trainer, facilitator. A lot of my knowledge about autonomic dysfunction comes via COVID, but I've thought about this long and hard, but I will say that I also had significant autonomic dysfunction myself, and that stems from well before COVID. So that's how I know a lot about it, from a personal interest about it. And yeah, so I think it's worth saying. And from that, I had connections with one of my treating physicians, the great Professor Christopher Matthias. And so early on in the pandemic, he and I did some work together to try and raise awareness about autonomic dysfunction. But my involvement has been in occupational health. I've led on the occupational medicine guidelines, which have gone worldwide. And I was an author on the WHO guidance on rehabilitation after COVID, in particular with the autonomic dysfunction parts, but also the return to work parts, and work with various other people on that. And the other, I just want to tell you a very little bit about what occupational physicians do, because actually we know about autonomic dysfunction in quite a weird way. We deal with toxic exposures in the workplace. So I've looked after many workers who have been exposed to nerve agents through their work, and part of my job was to monitor them. So I have to know about what nerve agents do to people, to put in place emergency treatments for them if necessary, to detect the problems and assess them, and so on. So that's quite an unusual thing, and I'll just bring in a few points about that later on. The other thing that we're very involved in is helping people return to work. And that there's been so many people post-COVID who have really struggled to get back to work. Well, one thing I want to mention up front is when we're assessing people, particularly with regard to blood pressure and heart rate and so on, is please avoid slavish adherence to figures, okay? It's a global clinical assessment using history, examination, relevant testing, and so on. Excuse me if I do kind of talk to some of the doctors here, but I do mean all relevant healthcare professionals. I'm assuming that I'm speaking to people who are very much interested, but I think autonomic medicine has been really under-resourced, and we don't know about it very much in medicine. We don't really practice as if we know much about it. But we all learn about physiology when we're at medical school. And what this is about is applied physiology. So we do know stuff already, and we do need to upskill, because I think the one thing that COVID has brought to the table is a real shift in the amount of people affected. So viruses are the #1 cause of autonomic dysfunction worldwide. And we've known that before COVID, and we've got so many people affected now. So I think there's really an imperative for all healthcare professionals to know some basics. And of the things that COVID causes and other things, autonomic dysfunction is one of the most debilitating things if left unmanaged. So just a few big picture things to say as well. Professor Matthias said to us at the beginning of the pandemic Great world events have always led to leaps in understanding of the autonomic nervous system. And I think we see before us one of those. I think we see before us a lot about how disease works. A lot of patients have said they were dismissed when they said their heart was thumping away post-COVID. Well, I say, when was anxiety the commonest cause of a tachycardia in a pandemic? So we must not dismiss our patients. And I do know that we're talking to the converted here. So Susie asked me to talk about a couple of things. One is resources, which I'll say a bit more about in a minute. But one is, who owns autonomic dysfunction? Currently, nobody. We've heard about how services have just been cut to the bone. My answer is that every doctor and every healthcare professional needs to know a bit. I would love to see that we had one ambassador in each medical school or health training school. That's what we need. So my job is to convince you of that, and hopefully to be able to go out there. In general practice, we talk about puns and dens, or we did when I was training, which means patient unmet needs and doctors' educational needs. So I think some of the basic tools can make our lives easier as clinicians. So it's like diabetes. Everybody needs to know a little bit about it. We all need to know a bit about this. We've heard how autonomic dysfunction can affect any body system. And I think it's really worth thinking. We've talked a lot about the cardiovascular aspects, but there's skin, there's genitalia, there's the gut. Now, the gut is often forgotten about. I think it's really, really common presentation of autonomic dysfunction. What I've noticed is that, and I can't quote any science for this, is that in particular children are affected by the gut side of autonomic dysfunction. And I think in general, if there's any pediatricians here or people that are looking after children, children get autonomic dysfunction too. And at the current time, they are being so very sadly neglected. Treating these conditions can actually help their day-to-day function at all ages. So much it can make the difference with returning to work and not. So I think I said I'll tell you one or two weird and wonderful things. If you think about, say, for example, the nerve, basically anything that is able to affect the autonomic system has to get into the nerve somehow. And it can do that by a big dose, one big dose, which knocks a whole load of things off in quite a serious way, or it can be low dose and repeated. So recurrent COVID infections are really making people worse if you've already got autonomic dysfunction. I mentioned about some at-risk groups for autonomic dysfunction. I've mentioned about post-viral conditions, Ehlers-Danlos syndrome, and hypermobility spectrum disorders. It's just too big a topic to go into too much. As Susie says, watch our video. But we know that people with Ehlers-Danlos get autonomic dysfunction. So it's having that high index of suspicion in certain patients. People with diabetes get autonomic dysfunction, suspect it. People with spinal cord injury get autonomic dysfunction, Parkinson's, and so on. There's quite a lot of diseases that people already have where we know they're particularly at risk. Treatment and assessment. I think this is perhaps where I'm going to just try and share some slides just briefly. Yeah, let me just do that. I hope this is going to work. Slideshow. So here's some resources really. In terms of assessment, we've mentioned some already. Here's a little extra one that was Professor Mathias adjusted for use at home, because so many people are affected. This is a simple thing. If you look it up online, and I put a quote to a study there. I was involved in the NIHR study called Locomotion, and they studied this adapted autonomic protocol. It's good for looking at the cardiovascular responses to waking up, getting up, standing up, food, and certain activities. So that can be quite useful for monitoring treatment and so on. Have a look at that reference online, it's quite useful. Again, from the Locomotion study, they looked at a number of patients in the clinics. As Deepak said, he was involved in these as well. 20% of the patients with post-COVID problems met the criteria for orthostatic hypotension or POTS. That's 20%. However, you couldn't necessarily judge this by the symptoms that they presented with. So they looked at the symptoms that people had, and then they did the tests. I mean, I put an Nasaline test here, but the active stand tests or the passive stand tests. The symptoms didn't necessarily correlate. So the point is that you have to screen for orthostatic problems in every patient in these situations. And you can do it in the simple ways that we've just said. I'll give my own example. I have extremely low blood pressure. I didn't realize, this is well before COVID, that it was actually causing my symptoms. And a friend used to describe it as like hitting the runner's wall, only I hadn't run very far, I'd walked a few steps. And I would have to sit down on a wall, kind of regain some strength, walk a few more steps, and then it would just get less and less. And then it was discovered that I had extremely low blood pressure. I was put on simple drug, fludrocortisone, life-changing effect. But the point is, I didn't know that my symptoms were caused by that. And the life-changing effect is that I'm able to do things upright now. So screen it in all your high-risk groups. This is the questionnaire for autonomic symptoms that Susie was mentioning. It's called Compass 30, up online. It is merely a checklist, but you can send this out to patients before you see them. And it gives you an idea whilst you sort of learn the pattern recognition of the types of problems or the symptom burden that people have. Anaesthetic, surgery, nil by mouth procedures, a big trigger for problems. If you have a general anaesthetic, your blood pressure drops. Your heart rate and blood pressure are deliberately altered according to the operations that you're having. So this can be really problematic. But if you tell the anaesthetist, look, I have got autonomic dysfunction, and that sometimes the simplest thing to say is, treat me like you would one of your diabetic patients. And I find then that anaesthetists do, understand this quite well. I've put Imperial NHS Trust understands this very well because I know they do. I'm a patient there, but it's because the autonomic unit was also established there, and people like Boon. So the anaesthetists and the other clinicians are really well trained in how to prep us if we have nil by mouth procedures. If you're nil by mouth, even if you're not undergoing an anaesthetic, you can be really fluid depleted by the time you get your procedure, and that's not good. I've put a number of other resources there for you to look at. So, management. Avoid any recurrent hits to your autonomic nervous system. Treat early has been mentioned. The earlier you treat, as in most conditions, the earlier people recover, the earlier they get back to work. I put there, don't give bad advice. What I mean by that is it is not deconditioning. It is not just get back to your normal activities. You've got to adjust for the autonomic dysfunction. So good advice would be programs like Susie's, because what that does, it supports the autonomic nervous system. It gets it going in the right way. I'm saying, in a sentence, just some very huge things here, but exertion. You have to take account of the autonomic dysfunction. You have to exclude red flags. I'll show a slide with that you can look up later. There are many disease-specific resources, such as the post-COVID ones. The Ehlers-Danlos Society's got excellent online resources about autonomic dysfunction. POTS UK's got simple, brief, POTS on a page type things, medications, and so on. I'll leave these up here. These are the clinical management of COVID-19. The rehab section talks about the red flags. There's 4 red flags to rule out before recommending exertion in people post-COVID and any other post-viral situations. Backed up by a strong evidence base, actually. So I direct you to look at that. That's one of the documents that I led on, long COVID and return to work, what works. Now, I'll let you into a secret, which will obviously now be all over YouTube, but actually I wrote that for the appendices, which are written with a lot of different specialists about assessment and treatment, okay, including autonomic dysfunction. This is a technical slide to end on. There's really emerging research that there's an association between autonomic dysfunction and the autonomic nerve endings and immune dysregulation, in particular mast cells. The mast cells and the autonomic nerve endings share the same type of receptors, and so there's what's called a bidirectional relationship. Susie and I heard about this in the day that we went to, and there's a reference there to that. So there's a lot to learn and unlearn, and that I'll make these slides available afterwards. Hope I've kept time, Susie.
I'm afraid Susie has locked herself out of her system, which is quite interesting. I guess think you're on time and maybe just a bit over, but I just wondered whether or not, in the interest of time, whether we can have Caroline rejoin us.
Yeah.
Can you just unmute and let's have a look to see whether Caroline's audio is now coming across better?
Just swapped laptops. Is that any better than last time?
Wonderful, amazing. So
Excellent.
you introduce yourself and continue, because we really couldn't hear anything you said the first time. So take it away.
Yeah. Hi, everybody, and I'm sorry about that little bit of technological shenanigans there. My name's Carolyn, and I'm a GP in the Highlands of Scotland, in what is at the moment freezing cold, windy, and rainy Nairn. And Susie asked me to come along tonight to primarily speak about my own experience, but in the context of we need to get people talking about dysautonomia. We need to get it taught, and in order to understand why we're not talking about it and why it's not taught, I am going to offer you all an apology, first of all. And I see from the chat, there's an awful lot of people who are already on board, and a lot of you have lived experience, as do I. So I apologize from the outset, because I'm going to reference past teaching and conversations that I have had that are triggering, and they are ill-informed, they are factually incorrect. But I ask you to bear with me, because to fix a problem, we have to first acknowledge that something is broken. And I've just realized that I edited this once I was listening to the other ones, and I took some of the more triggering, horrible stuff out, and that one's over here and the old one's over there. So I'm going to look in this direction for a wee bit, so apologize. So when I went to uni in the late 90s, we were fed a very strict diet of anatomy, physiology, and biochemistry. The moral of every tale was that illness was associated with structural anatomical abnormalities that we could detect with tests, and we treated them with drugs or surgery. That was it. And being a sentimental sort, I actually have them under my laptop to raise me up. I still have our core textbooks from first year and our Beginner's Guide to Medicine. And I had a look today, and there's quite a wordy chapter in the physiology book about the autonomic nervous system and how it functions, but there's no suggestion that it might dysfunction. And Kumar and Clark's 4th edition War and Peace of Medicine 2 has 2 paragraphs on chronic fatigue syndrome, tucked away in the psychological medicine chapter, almost at the very end of the book. And given the absolute lack of any lovingly highlighted text from the late 90s, I can only assume I never read it because it wasn't part of our core curriculum. Now, you can only learn so much about how to be a doctor from textbooks, and the real learning, I feel, comes from our senior colleagues, these fonts of knowledge who've been there, done that, and they swoop in at the 11th hour to fix the people who are the most unwell when you're a junior doctor and you have no idea what to do. So when one of these senior colleagues tells you that the most important thing to learn early on is how to avoid mental people, you listen to them. His advice: if you see the next patient in the queue with purple hair, a single crutch, soft collar, and tinted specs on, go get yourself a coffee until somebody else picks up their notes. Now, fast forward a couple of years, I see that you understand why the apology was necessary, and I mean it. Fast forward a couple of years, I find myself working in emergency medicine, where the rhetoric was very much a case of see him, treat him, make him somebody else's problem. And we used to lament the plight of GPs because they had to follow up this unfixable bunch. Unfortunately, becoming a GP was necessary to me to get the job I really wanted. So with great reluctance, off I went to follow up hell. And hell it was, because I did not know how to fix the unfixable. We spent whole training sessions discussing the heart sink patient, the ones who kept on coming back despite us having nothing to offer them. We were taught about the ICE framework to improve efficiency and reduce unnecessary prescribing. Ideas, concerns, expectations, and we had to use it in every consultation in order to get through the damn exams. What do you think's wrong with you? What are you worried about? And what do you want me to do about it? Efficient, but it's not exactly holistic medicine. And if all this sounds pretty bleak, it should, because it is. But I didn't think it was at the time because I didn't really know any better. And in October 2021, if you'd asked me then, I would have said life was pretty much as good as it got, with the pandemic notwithstanding, obviously. But then I got COVID. And it was nothing drastic, you know, fever, fatigue, with a smattering of, you know, general COVID-y symptoms, but nothing that would have made me take a day off work if it weren't for the isolation guidance. But then that first day back out in the world, as Boon has mentioned, I can tell you exactly what happened. I went out to plant some bulbs in the garden, and within half an hour I thought I was going to die. I had to lie down, my heart was going like the clappers, and I thought I was going to pass out. I just assumed that I was still run down, revived myself with some tea or toast as I was so used to, and I had a rest. And the following day, I'd been tasked with grabbing some bits for a kid's birthday party in the shops, and I remember vaguely staring at the balloons and the banners for well over an hour, and I just didn't know what I was doing. Had no clue at all. I couldn't figure out why I was there, what my goal had been. I just knew that I had to look at these damn balloons, and I walked out without buying anything. I tried to go back to work. My brain refused to function. ECGs were gobbledygook. I'd forget a patient's history between leaving the cubicle and writing my notes up. I couldn't remember drug dosages, even something as simple as paracetamol. I'd have to check the BNF, close the book, and then by the time I came to put pen to paper, I'd completely forgotten the damn dose. I managed 6 hours of that first 12-hour shift, and I had to go home, and I'd already fallen asleep twice during the shift. I knew something wasn't right, but at that point I had no insight into quite how not right things actually were. I went to see my GP, reeled off my symptoms, and by this point the list had grown to include headaches, chest pain, breathlessness, dizziness, ataxia, tinnitus, myalgia, insomnia, blurred vision, glove and stocking paresthesia, palpitations, complete inability to concentrate, no memory, and the most profound fatigue that felt my body was completely shutting down. You can see my breathlessness has disappeared. But the script duly unfolded. I thought I might have long COVID. I was concerned I had MS or myocarditis. I expected my doctor to make sure that my symptoms weren't being caused by anything sinister, and to my shame, sign me off work. And I remember coming out feeling like I'd literally had to beg for these blood tests and an ECG. And I remember the GP saying to me, but we won't bother with a troponin, will we? I had to beg them for a damn troponin. And I later found out that this consultation had been coded as anxiety. Now, unsurprisingly, all the tests came back normal, which I found out from the receptionist after I phoned to find out. There was no follow-up, there was no discussion. That was it. And not only did I now feel physically and cognitively broken, the shame, and there's that word again, of now being one of those patients was completely crippling. Now I was one of the medically unexplained. Feeling incredible pressure to do so, I tried to go back to work again. And a note to any occupational physicians listening, do not tell people-pleasing type A personalities that they should choose their own hours for phased return. Because what did I do? I did too many, far too quickly. And despite my cognitive challenges, no restrictions were put on what I should or shouldn't do. Didn't go very well. One consultant showed me great sympathy by suggesting, and I quote, that I dye my hair purple because that's what mental people do. On another occasion, I was offered ECT with a defibrillator. When I suggested there may be a link with long COVID in POTS, a colleague declared, oh great, another made-up condition. I didn't last much longer, and I handed my notice in just after New Year, at which point my boss asked me if it wasn't just stress. It occurs to me as I reflect on that time that a number of people with medical issues, post-viral or otherwise, were in my kind of sphere of association. And my male colleagues were all treated very, very differently. One with the chest pain post-COVID was referred to cardiology. He had full buffer of investigations. He was empirically treated for myocarditis, despite the fact that all his investigations were completely normal. Another was referred to neurology. Another one went to rheumatology, gastroenterology, cardiology, and neurology. He almost got the whole 6 sides of the elephant. Male patients were far more likely to have their symptoms taken at face value. They were far more likely to be referred for specialist review, and oftentimes they were treated in spite of negative or equivocal investigations. Women were told it was all in their head, had to beg for investigations, and given no options for treatment or support other than a trip to the hairdresser. So a friend mentioned to me that a long COVID clinic was being set up in our area, and again, I had to ask repeatedly for a referral. And I think that was the real changing point for me. And it wasn't because I was suddenly getting investigated or being referred. It was the first time that somebody clinical listened to me and they actually believed what I was telling them. And after an hour of hopeless rambling on my part, the consultant declared that of course there was something wrong with me. I had long COVID and quite probably had POTS into the bargain. And at this point, I just burst into tears and begged her to tell me that I didn't have a functional illness. So ingrained were my years of poor education on the subject that even after suffering for over a year with my so-called medically unexplained symptoms, I was still gaslighting myself into believe that I was malingering and a functional illness was the equivalent of me imagining it all. But they referred me to this lovely occupational therapist who must have completely despaired because all I wanted her to tell me was when I knew I was cognitively well enough to go back to work and drive and how I could prove it. But she signposted me to a podcast, which was where I first encountered the lovely Susie Bolt. And Susie spoke of something that was previously unheard of to me, which was recovery. And if somebody with a condition like mine could recover, then there was no reason I couldn't. And for the very first time since becoming unwell, I felt that there was actually some element of hope. And I was still managing to work, but in a management role, which probably tells you plenty. But I couldn't fit in the rest of peer recovery program. But I still used the principles and learning and very gradually started to see improvement. I identified activities that could downregulate my nervous system. It gave me more stamina. I was diagnosed with a breathing pattern disorder. And for once, I actually did the physio exercises and my breathlessness went away. I used every non-pharmacological intervention going for POTS and I finally slept. Little by little, I recovered and I got my life back. So having been discharged in the long COVID clinic, I started working for them. And I have to say that seeing other patients with the same bizarre symptoms I still hadn't told anybody about was incredibly therapeutic. And I genuinely have to thank them for being the final piece of my recovery puzzle. Interestingly, we received more referrals for women initially, but gradually this has evened out, with more men now being referred, albeit later, and with far more investigations being done beforehand. And at the beginning, we didn't have much to offer other than validation, support, and hope. New research would come to light on an almost weekly basis, and we'd consider it, but there was no one single conclusion that fit every patient that we were seeing. But what if there was something that could influence heart rate and breathing pattern, energy use, availability, immune function, inflammatory response, but it was there all along in the blooming physiology textbook. Regulatory functions of the autonomic nervous system in response to physiological and psychological threats. This is primal. Physiological and psychological, body and mind. And in clinic, we use the knowledge that the nervous system is influenced by both to help relieve and manage symptoms. In effect, mind-body medicine. And during a return to practice, general practice, I actually had a bit of a revelation. About 70% of what came through my door in GP land was either caused by or exacerbated by autonomic dysfunction. And our lack of understanding in this field results in poor patient journeys and professional dissatisfaction because we can't help the patients and we are frustrated by the fact that we can't help the patients. We over-investigate, we over-prescribe. It's not realistic medicine, it uses more clinical time and it costs more money. And most importantly, the patient outcomes are poor and the symptom burden remains or increases. The effects of dysautonomia can be just as disabling, if not more so, than conditions associated with positive diagnostic tests. Knowledge is power, and we need to give that power to the next generation of clinicians who will challenge those archaic beliefs of the previous generations. We need to work together, not as specialties hidden off in various corridors of the hospital. We need to come together and share knowledge to better understand how to promote recovery and optimize symptoms. We need to return to practicing whole body medicine and understand how what was once our evolutionary advantage is being eroded by the modern lifestyles that we all have. To sum up, I was once the victim of my generation, but karma, thankfully, gave me a dose of my own medicine. We have become overly reliant on investigations and pharmaceutical interventions, and our dismissal of symptoms in the absence of positive findings is actively causing harm. Now, I've considered these questions and I've got my own theories, but what gives us the right to suggest there is nothing wrong or that symptoms aren't real? Why do we find acknowledging symptoms in the absence of positive tests so difficult? Why does gender impact how we treat and refer patients? Could the single crutch, soft collar and tinted specs represent someone who's lost confidence in their balance and their mobility, has coat hanger pain and light sensitivity? If so, why do we write them off? We have known and we've understood the man-body connection and the relationship with the nervous system for millennia, and we need to re-educate our clinical staff and educate those coming into the system. This will have advantages for patients and clinicians and take the burden off the healthcare system. And if I haven't convinced people yet, the last time you ran up the stairs, did your heart rate go up? Did you feel sleepy after the big meal that you ate? Have you ever blushed? Did you mean to? Could you control it? Was it inconvenient? Was it embarrassing? Maybe, but these are all examples of involuntary physical responses to physiological or psychological stimuli that are mediated by our nervous systems, and we all have them. So as a profession, it's about time we recognise and acknowledge them in our patients. And I shall get off my soapbox and hope I didn't offend anybody too much, and ask if anybody's got any questions.
Oh my God, Carolyn Forsyth, what a showstopper. That was the call to revolution, guys, if there ever was one. We have been waiting for you. We have been waiting for you to bring those words in at the end, because it is all so true and so relevant. I am so pleased that you've just said what you've done. I am going to be sharing that particularly far and wide. And so refreshing to hear it from a doctor. And I can see a lot of people giving us the round of applause emoji for those people watching this later. Now, I haven't been watching the chat box. I've had to relocate to a different screen in my house because my master computer logged me out. But please do, any of my other team here, let me know if there's a particular question that we should be picking up as a result of this. I can see that there's been lots of activity. Boon, you've been ferociously responding. Claire too. I think Deepak's getting involved. But tell me, is there one that we should be talking about? Boon, you've come off mute. Yes.
So I'm just going to say that there are a lot of questions on the chat about specific therapies for your condition. So I think Leila wants to know about measuring antibodies. Sorry, I don't want to get your name wrong. Wants to know about supplemental oxygen therapy. And I guess I want to come back to Susie's vision here. This is a talk about dysautonomia. And I want to put that in the context of the blind man and the elephant, because, and that's not to say that every single bit of treatment will help, right? We have to trade this ground carefully, and as healthcare providers in a space with very little evidence base, and with the evidence base shutting down with the closure of clinics or the closure of funding to long COVID type research, it comes down to the point of, and I'm afraid to say this, but experience where I learn from my patients what works for them. So there was a question on neurostimulation. I've had about 25 patients use it, and half of them do very well with it, and half of them think it's a waste of money. And same with the Sensate. I think Susie also has this Sensate vibrating thing on your chest. Same with electromodulation devices like the pulsetto around your neck, the NeuroStim. And I guess my own N=2 experience with IVIG, when I've tried to push hard for it, is that it doesn't work. And there are a lot of barriers to get IVIG to prove that the antibody does exist. And that is a fight that I've seen being fought in the dangerous world of, for example, plasmapheresis, which was all the rage at one point. But you'd have to travel to South Africa or Germany and mortgage, or get a loan or do a partial mortgage on your house to have this 6 courses of treatment for God knows how many thousands of pounds. Or, for example, hyperbaric oxygen, in which the evidence, not evidence, but what they publish is that you need 40 sessions. Now, per pop at 1,000 odd pounds is going to set you back with no guarantee of success. And these are all the things that people are drawn to try and say, oh, if only I did this, if only I got that, if only I got to see Boon Lim, he would fix my problems. And this help me Obi-Wan Kenobi is not an approach that you should be doing. It's actually look in the mirror and understand what you can do to help yourself. And I know there's a lot of frustration. I can read it in the chat about how this GP or this ICB or this person has failed me. They haven't done enough. But actually, if you consider that one of the things that you might do is evolve to ask the correct question. And I think this is part of what Susie is trying to do, or gather support to do, and go back to the root cause and really understand the facets of the elephant and understand how you can fundamentally shift. And I did write in the chat that despite saying what I've said, I would say that treating orthostatic intolerance is a good first step, but I'm very biased. And Deepak might say treating chronic pain as a trigger for autonomic dysfunction is also good. And there are resources for you to read and learn more about this. And most of the treatments are very much lifestyle based. And I guess that is the messaging that we want to get across, that it's not, the answer isn't going to lie in the neurostim or the sensate device or the IVIG or the plasmapheresis. The answer is more subtle than that and much deeper than that and much more long lasting than those things that you think will help you. Don't know, Susie, if you agree or if there's any other.
I agree. And I think, having worked with so many people, and I'm not a doctor, I don't have that training, but what I have done is become absolutely hyper-focused with all of the ability of a woman with ADHD, hyper-focus on this topic. And having worked with many people who have gone on to make significant recovery, the thing that I have put together is my own kind of route map of things that make sense. So yes, where appropriate, take your antihistamines, take your LDN if it works for you, get your heart meds if that is really important and a significant symptom, and then really begin to understand what recovery means. I like to talk in the FERN program, which is the kind of smaller group coaching thing that we do. I like to talk about us as a plant that's been really damaged. And so we actually need to create all of the right compost around us to support recovery and growth. And actually, most of us are not very good at that because we just do not have the capacity to think about it or give ourselves the time. But when we take ourselves away as much as we can from stressors, and I ask people in the phone to take the news app off their phones, to if they can, take time off work, proper time, to learn how to properly relax that doesn't involve sitting on your phone scrolling, to stop doing deep research into some little kind of thing that someone did with 8 people, said, look, oh, you're all going to get brain damage as a result of this virus. All of that is so triggering for the autonomic nervous system. And yet we're doing it because we think we're trying to help ourselves get better. So we have to really look at our own behavior around how am I expecting my body to recover, and what are the conditions I'm providing for it? So I'm a really big fan of helping people also think about what are the conditions I'm asking my body to learn how to recover in, and really begin to work on the nutrition you're giving your body, the kind of rest you're having, the things you're exposing to that are stressed. And a lot of it will be looking at your behavior drivers. Are you someone who is wedded to helping everyone else before you help yourself? Are you someone who is having to do everything really quickly because your hurry up driver says, I've got to do this, and then I've got to do that, and then I can't not do that, and I've got to do X, Y, and Z? Or maybe you're someone who just doesn't like asking for help and just sucks it up and pushes through every single flare up until your body just says, no, I'm going to just shut you down because you're not treating me with respect. You're not treating me with kindness. and you're asking me to do too much before I'm ready to. So whatever it is, I really talk about the importance of those factors. And I think we've become so hyper-focused on medication and give me something that I can take, that I'll consume, that will make me better. But we need to help that happen ourselves. And many of us don't. You know, we're surrounded by medications that, oh, you take that and then you can go back to work. You know, it doesn't work like that with this kind of condition. Because I really do think it's like the brain says, not anymore, not like this. Thank you very much. You need to undo some of your being. And that, I think, is the hardest part of recovery. You actually have to fall in love with looking after yourself, which is something that many of us do not want to do because it involves change. And that change is too uncomfortable. You might have to look, as Boon said, you might have to look in the mirror. But those are the things that we also need to be talking to patients about. How are you helping yourself? And it's a big conversation, and it's not an easy one to have in 10 minutes. I completely understand. But those are important criteria. When that person is coming back again and again, you can have that conversation at some point in that journey because it needs to be had. Most people don't know how to rest. They just don't know how. Claire, do you want to say anything on this one before we move towards closing?
I think you've just said that very, very well. I would reiterate though that I think it is a call to arms of people, you know, health professionals, to be able to assess things, advise when treatment is sometimes necessary, and really anything that can support the autonomic system. So yes, the holistic picture, but understanding that it can be managed, and people, and it will make our lives easier as health professionals, but it will make many patients' lives easier as well. I don't like to separate patients and health professionals, but yeah, you know what I mean.
Yeah, absolutely. And you're right, absolutely. And there are people for whom recovery isn't necessarily a destination that's going to be a choice that they'll have, but managing their systems, managing their symptoms will be something that is within their reach. And I think helping people achieve a better quality of life is absolutely all of our jobs, right? So yeah. Carolyn, you want to say anything after your magnificent speech?
I think the point about perpetually chasing the silver bullet, the magic cure, that's the bit that I think is really important, because that's where I see people get stuck.
Yeah.
I'm going to paraphrase something I once said to a patient at GMC, probably wouldn't have appreciated, but they weren't there to hear it. So ducks are heavy, and the more ducks we give, the heavier the load is on our nervous system. So we need to stop with the ducks, and we need to set some of those ducks free. I'm sure you know where I'm going with this, but that, you know, perpetually pursuing that, what if the drug, or what if the test, and what if this, and what if it's mold, and what if it's Lyme, and what if ultimately, if we agree that all of this is your autonomic nervous system playing havoc, whether it's any of those things, regardless of what duck is involved, then let's look at your autonomic nervous system and let go of all these ducks and get rid of all that weight that is on your nervous system. And actually, that in itself will give you the lightness and the space from which to start healing. And that is the point where I feel that my patients start to get better. And I'll stop quacking on now.
Getting your ducks in a row, Carolyn. Love that. Deepak, do you want to finish with anything? Come off mute. Come off mute. Come off mute.
No, thank you so much, Susie, for inviting there. I think, Caroline, that was fantastic to hear what you said. And realistically, you're absolutely right. I think what we need are those specialists who can look at the whole mind body picture there. And maybe you're already part of the group that there is that growing recognition and increasing presence of clinicians across the UK who are taking on this mind-body approach and coming at it with patients. I think the challenge we have now is to connect all these dots, connect all these clinicians, and connect the resources together to make us stronger to actually then pitch or ask the commissioners and the powers that be to make this a bit more mainstream than it has ever been. And I think that tide is changing now thanks to conditions like COVID. So when the next post-viral drama comes through, we should be better prepared and more, ready.
Amazing. Yeah. right. There is always what's ahead. And being prepared, my goodness, wouldn't it be great? Folks, let's finish on time. There's obviously a lot more that we could talk about. You know, I also want to talk about making sure that we're reaching communities that we don't reach via social media. So how do we take care of those people that don't know how to access this kind of information? There is a lot that needs to be discussed, but this is just the first event. So thank you so much for showing up. Amazing. Thank you all to the doctors. You know, what an incredible gift of your time. I really appreciate it. And I hope everyone that is watching this either live or on catch up has enjoyed it as much as I have. There will be another one and we will work out what that topic is. So all within the umbrella of dysautonomia, but thank you so much for attending. Your attendance has made it all worthwhile. Thank you guys. Go enjoy your evenings.